And welcome to our grand rounds for the Department of Medicine. I'm Dr. Kim Allen Williams, the department chair, and it's my pleasure this morning to introduce our introducer, Dr. Rosemary Youssef, who is professor and chief of our Division of Nephrology here at University of Louisville. And we have a very special guest who will be speaking this morning about changing paradigms in hemodialysis vascular access, dawn of a new era. Dr. Niyyar. Dr. Youssef.
Good morning, everybody. And I am so pleased to introduce Vandana, who was a resident. I have to look for what time period. She was an internal medicine resident here at the University of Louisville from 1999 to 2002. So this is part of my series of having people who have been at the University of Louisville, either as a resident or a fellow, come back and give us talks. So this was part of our division chief prerogative that I'm introducing her, because we do have a medical director of vascular access, Dr. Amy Dwyer, who I know has been working with Dr. Niyyar in the American Society of Diagnostic and Interventional Nephrology, but I stole this introduction because I wanted to do it. So she is, I don't know, we used to say a triple threat, but I think it's a quadruple threat. Someone who takes excellent care of patients, has been doing research all along her career, has a lot of awards for teaching, not only residents, fellows, other physicians, and how to do interventional nephrology, and has engaged in a lot of administrative type work and national leadership in guidelines in vascular access. The other thing that's very impressive about her is she's always learning. So whereas she may have started with interventional nephrology, she's now a big proponent of point of care ultrasound and has been teaching courses on that. She has many awards, and I think the one that I'm just going to highlight here was for American descendants of Indian physicians, because I got to be present. It was during a Zoom award ceremony, and her whole family was at her house. She was getting the award. It was such a special event, even though it was a Zoom event. But she has multiple awards from the ASDIN, from the American Society of Nephrology, and other national and international organizations. So I'm so pleased that she's here, and everybody, you're in for a treat. I know it. Thank you so much for giving the talk.
Thank you so much for inviting me, Dr. Youssef and Dr. Williams. And I just have to say that I don't know if a lot of people know that, but Dr. Youssef is the reason I'm a nephrologist today. She decided when I was a resident, actually I was an intern rotating with her, that nephrology was the way I was going to go. And Dr. Youssef is the reason, literally, that I am a nephrologist today. And I was such a pleasure to see Dr. Casper. She was the first, I guess we were her first class when she was PD, and to see all the people that I've learned so much from, Dr. Klein, Dr. Lederer, Dr. Aronoff, and everybody else. So I'm really excited to be here and to share some of the work I've been doing since I left Louisville. So if we're ready to start, Jason, you can share my slides. And what I'm going to talk about today really is, so I did give grand rounds here at Louisville. I was looking through my CV, I think it was 2008. So at that time, interventional nephrology was in its infancy. And for us, it was really, we were at the start of a new era. And now we really have completely changed the paradigms in the last 10 or 12 years. So I'm gonna walk you through the path that hemodialysis vascular access is taking, and it's a very exciting time to be an interventionalist at this time. Jason, next slide, please. And these are my disclosures. Some indications I discuss will be off-label. And next slide, please. So these are the main objectives. What I want to do is walk you through the evolution of vascular access for dialysis, and then focus on some innovations that we have seen, especially in the last 5 years in hemodialysis access creation, and then also discuss some innovations in the process of care. How can we change the paradigms and challenge the status quo? Next slide, please. And so when I think about this broad audience that's here at Grand Rounds, I want to make sure that I talk to each one of you. And each one of you is going to come across a dialysis patient. It's critical for us to understand what are the subtle nuances of the dialysis patient today in 2023. So this is slides from the USRDS data. You've got time on the x-axis, and on the y-axis, you have cases per million persons. And you can see that we are dealing with an aging population, a population 65 to 74, and the 75 plus, that is the largest growing demographic as the dialysis patients. Next slide, please. And most of our patients have a lot of comorbidities: coronary artery disease, congestive heart failure, infections, malignancies. And these patients are sick. They have a lot of comorbidities and a lot of vulnerabilities. Next slide, please. And this slide has stayed with me ever since I first saw it. The line in dark green are the patients on dialysis. And you can see their 10-year prognosis is worse than those of patients with invasive colon cancer and invasive breast cancer. Next slide, please. And when you think about dialysis, so the line in red is dialysis. These are the patients. Look at the mortality rates in patients, even if you look at all comers with ESKD, or you look at patients who have strokes, heart attacks, heart failure, diabetes, and cancer. The mortality rates, the line on top in the red, for dialysis patients are the highest. Next slide, please. And so it's critical when we are dealing with this population that we have to know what it is that our patients want. What do they need from us? What can we provide them as their physicians, as their care providers, as their advocates? So this is data from the SONG HD study, where they had the Delphi panels, where you have sequential rounds and everybody discusses what they think is important, but you can change your opinion in the next round based on what other people think. Next slide, please. And so here you can see that the patient bias, patients, what they wanted was the ability to travel, to be independent, their time free from dialysis, how they felt after dialysis. While physicians, we traditionally look at metrics that we can measure. Metrics like death, mortality, hospitalizations, infections, hypertensions. And so there was a huge disconnect between what patients wanted and what physicians thought was important. Next slide, please. And so, next slide, please. It's up to us to balance the needs of the patients with what we consider important. And so, next slide, please. When these Delphi panels, they actually sat together and they discussed, they came up with 4 core domain outcomes that became critically important to both patients and physicians. And not surprisingly, vascular access was one of them. Next slide, please. And next slide. And so when we talk about dialysis patients and we group them together, yes, they're all vulnerable. Yes, they have lots of comorbidities. Yes, they have a lot of different problems. But when you think about each individual patient, they can be very different. So for example, we might have a young female who only has end-stage kidney disease secondary to GNs, has no other comorbidities, works. What she values and what she needs is a focus on her role as a mom, as a wife, as an entrepreneur, and she really values independence. On the other end of the spectrum, you might have an 84-year-old who has end-stage kidney disease secondary to diabetes, but also lots of comorbidities, who might be living with extended family, who may value the fact that they don't want to be a burden to anybody else, and they really crave that human connection. So what we need to do is to individualize each dialysis modality and each dialysis access option. Next slide, please. And next slide, please. And so it's our goal as providers to make sure that their lifeline, because their access is their lifeline, it's the only way that they can get dialysis, should last for a lifetime. Next slide, please. And so when I took over as Director of Vascular Access Care at Emory, we wanted to make sure that we were very intentional in how we provide and optimize the best access for our patients. So for this broad audience, I did want to highlight some of the things that I think are critical for everyone to understand. When we move towards a functional access, we need to start at multiple levels and try to have a multi-pronged approach to finally get to that pot of gold at the end of the rainbow. Next slide, please. So first, let's talk a little bit about vessel preservation. Next slide, please. This is key because having a functional access is critically dependent on the patient's peripheral as well as central veins. Multiple phlebotomies, multiple catheter use, including peripheral as well as central venous catheters, can lead to injury, phlebitis, sclerosis, stenosis, and ultimately thrombosis. Next slide, please. And the goal should really be to start as distal as possible. Start at the dorsum of the hands whenever possible. And the one thing that we have an absolute moratorium on is subclavian access. So when I first started training, subclavian access was the way to go because it was the way that had the lowest infection rates. But we also know now that subclavian access has the potential for central venous occlusion. And if you have central venous occlusion more proximally, you absolutely lose the ipsilateral extremity for any access. And so next slide, please. It's critical that we avoid subclavian catheters. We should also avoid PICC lines in patients with advanced CKD. So if you think of a PICC, because you see it coming out at the antecubital, most people assume that they are peripheral lines, but they're not. A PICC line is a peripherally inserted central catheter. You can see the tip is actually much more central than you expect. And these have been shown, next slide, please, to be able to associate it with a risk of central stenosis that can range between 7 to 38%. So the ASDIN, which is the American Society of Diagnostic and Interventional Nephrology, made sure that we had a white paper where we talked about ensuring that any patients who have advanced CKD should not be getting a PICC line. They should have a nephrology consult. And if they do need something for long-term IV access, it should be a small caliber IJ instead of a PICC line. Next slide, please. And so we went ahead at Emory, and now we have not only these guidelines for venous access in CKD patients, but we have incorporated that within the electronic medical record. So if someone orders a PICC line on a patient with a GFR of less than 45, the electronic medical record will automatically flag it, and then they will be asked to put in an order for a tunneled IJ. And we made that very simple. It just in one click, you can go ahead and change the PICC to a tunneled IJ. Next slide, please. The other part that we figured out that was lacking in a lot of our patients is patient education. Next slide, please. So the first thing, I strongly believe that education is empowerment, and you have to overcome the initial reluctance. And there's data to show that this is important, and patients who are educated about avoidance of phlebotomy and who were involved in the decision-making were much more likely to receive an arteriovenous fistula, which is considered the gold standard. Next slide, please. And so we created our own education for modalities. And this was a patient-centered video by patients talking to patients. And we now use it in all our kidney clinics, as well as, I'm happy to say, across the country. And we have had, as of when I last checked, more than 500,000 views. And so it is helping other patients make decisions as to what they can do and what is the best option for them. Next slide, please. And so now I just want to take you down a little walk down memory lane, talking about evolution of dialysis access and how we have expanded our armamentarium in the last 5 years. So this is a throwback picture of Throwback Thursday, first dialysis membrane. This was Thomas Graham, who was a chemist who used an ox bladder semi-permeable membrane as the first precursor to a dialysis membrane. Next slide, please. And this is a picture of Dr. Kolff. He was just a physician in World War II, and in a war-torn area, came up with the idea of basically washing a patient's blood. And he used a laundry tub, a wooden drum, and a cellophane paper, which turned out to be the first dialysis machine that was ever used in patients. And his student was actually Jarvik, who came up with the Jarvik heart. And Dr. Kolff is known as the father of the artificial organs. Next slide, please. And so as we think about evolution and innovation in the field of dialysis, these are the kind of machines that most of you are very familiar with, that you see across the hospitals. Next slide, please. To moving on to a wearable artificial kidney that is in clinical trials right now. Next slide, please. To moving on, hopefully within our lifetime, we'll see a bioimplantable artificial kidney. Next slide, please. But when we think about dialysis and how the process of providing dialysis has advanced, in the field of vascular access, there really hasn't been much advancements and much innovations until recently. So the 1960s, we saw the first time we could provide dialysis for more than one session by external AV shunts. So these were these Teflon U-shaped materials that connect an artery to a vein. But as you can see, not only would they be extremely uncomfortable and painful, but they would likely lead to stenosis and infection and thrombosis. And so in the 1960s, we couldn't really provide long-term dialysis for our patients. Next slide, please. And as we move towards hemodialysis access options, so when you think about hemodialysis access options, just one thing to do for the broad audience is to refresh our anatomy. The radial artery at the wrist and the brachial artery at the elbow are the two main arteries that are used for hemodialysis access options. And the two main veins are the cephalic and the basilic. So whenever we name an arteriovenous fistula, the name of the artery goes first. So if I say a radiocephalic fistula, it's a radial artery that's connected to a cephalic vein. So over the years, 1970s, 1980s, we had the development of the fistulae, which is, you can see a radiocephalic fistula, you can see a brachiobasilic transposition. And then we had grafts and the central venous catheters. Next slide, please. But if you think about the ideal access, and this is a radiocephalic fistula, what you want is an access that you can place and be able to use right away. You should be able, everyone in the dialysis unit should be able to access it repeatedly and consistently. It should have a sufficient blood flow for adequate dialysis, should be patent for a long period of time with a low rate of complications. Well, as of now, unfortunately, the ideal access does not exist, but an arteriovenous fistula for most of our patients is considered the gold standard. Next slide, please. And this is just a slide that compares the different vascular access types. The main issue with a fistula right now, or a surgically created fistula, is the primary failure rate, which can be as high as 20 to 50% based on which study you read. And then a fistula does take time to mature. So the time to first use can be as high as 12 weeks for a fistula that has been transposed. But once a fistula is placed, its longevity is measured in years. Grafts are intermediate between fistula and catheters. They are basically a piece of plastic that connects the artery to the vein when you don't have adequate veins for an outflow. And because it's a foreign body, the human body reacts to that by creating neo-intimal hyperplasia that can cause stenosis and thrombosis. So most grafts last on an average of 2 to 3 years. And then central venous catheters, they have certain advantages because they can be used immediately, but the potential for infections, the potential for central venous stenosis is very high, and their longevity is measured in weeks and months. Next slide, please. So when we look back at this history, in the 1960s was the first time we had a brachioseminal radiocephalic fistula. And in 55 years following that of surgical results, we still have a very high failure rate. It still takes us 3 to 4 months before we can get to 2-needle cannulation and be able to get rid of the central venous catheter. And despite our best efforts, 70% of our patients initiate dialysis with a central venous catheter. Next slide, please. And so this is now a very exciting time in hemodialysis vascular access. To this audience, I wouldn't go into details about all of these different innovations that are occurring throughout the field, but I'd like to focus your attention in one of them, which is the percutaneous or the endovascular arteriovenous fistula creation. Next slide, please. And so when we think about, like I showed you, our goal is a functional access. What if we were able to get rid of the surgical approach and move towards an innovation in access creation where we can create a good access without the surgery? Next slide, please. So we have expanded our repertoire, and I'm sure you might have heard of these endovascular AV fistula devices. There are 2 devices that have some similarities and some differences that allow us to create an arteriovenous fistula without surgery. Next slide, please. One of these devices uses magnets and radiofrequency energy, but it's a dual catheter system. And I have some videos that I'll show you, but basically you need to go in through the artery and through the vein separately, do this under fluoroscopy, and you can use the brachial, ulnar, or the radial vessels. The second device uses a TRAD system, which is a thermal resistance anastomotic device using heat and pressure. It's a single catheter system. So you go in through the vein, go through the artery, and then under complete ultrasound guidance, you can create this fistula connecting the proximal radial artery to the perforating vein that connects the superficial and the deep venous systems. Next slide, please. So here you can see this is a venous catheter that is being introduced and advanced to the site that is chosen for the AV fistula. Next slide, please. And then through a separate puncture, you go in through the artery, advance the arterial catheter to that same location. Next slide, please. And once these catheters are in place, we rotate them to allow the magnets to align with each other. Next slide, please. And once the magnets are aligned, we deploy the venous electrode. There's a 2-second burst of radiofrequency energy that's given that creates the arteriovenous fistula. Next slide, please. And here you can see that the fistulogram immediately post-op shows a newly created arteriovenous fistula. Next slide, please. And this is 24 hours post-procedure. It just looks like the patient has prominent veins, but you've actually created a usable AV fistula that can be used for most of us within 4 weeks. Next slide, please. And this is the second device, and this is a video that we could just play, which shows you how we use ultrasound guidance. So completely under ultrasound guidance, you first access the perforating vein, and through that, then you puncture the radial artery. And once you've done that, you can advance your guide wire directly into the radial artery, change it over to a 6-French sheath. And the 6-French sheath then tracks over the wire, again, through the perforating vein into the proximal radial artery. And once that's in place, the device is then mounted and it is advanced to the site of the anastomosis that we plan to create. And once the 2 walls are in position, you can go ahead and fire the device to make sure that they come in contact and then create an arteriovenous fistula. And this allows the blood to flow from the artery into the vein, creating that connection, creating that anastomosis that is a new arteriovenous fistula. Next slide, please. And when we look at the data from these devices, this is early data from these devices, but we now even have 5-year data. You can see that the demographics are very representative of the kind of patients that we see, patients who had a high BMI, who have multiple comorbidities like diabetes and hypertension, and a third or more than a third of these patients were already on dialysis at the time of the AV fistula creation. Next slide, please. And what's even more impressive, when we look at the primary and the secondary patency, it is in the 80s as compared to surgical AV fistula, where the secondary patency is usually around 60%. So these devices are showing at this point that their secondary or cumulative patency is in fact better, or at least equivalent to that of surgically created arteriovenous fistulae. Next slide, please. And so what they've done is they've allowed us to expand our armamentarium. So prior to these fistulae, our patients had options for maybe 3 or 4 in the upper extremities. But now, because you can use these sequentially, there are at least 6 options for each patient on each arm for them to be able to get an arteriovenous fistula and to be able to prolong the time that they are getting dialysis through a permanent access. Next slide, please. But there are certain limitations. You have to have the right anatomy. The initial data suggested that the proximity of the perforating vein to the anastomotic artery should be less than 2 millimeters. And the initial data that was published suggested that 80% of the patients have this anatomy. From our center, we are now finding that around 35% of patients have this anatomy. It does require a learning curve. So the interventionalist or the proceduralist should be experts in not just the procedure, but also ultrasound and fluoroscopy. They do require secondary procedures. And the main issue with them in the real world is because these are low flow fistulae and they may have split dual flows, sometimes it's harder to see them or feel them and much, much harder to cannulate. So we might be moving towards the need for ultrasound to guide cannulations in these axes. Next slide, please. So take home points for these. Next slide, please. Is that endovascular AV fistulae, they have good technical success, low complication rates, a good amount of cumulative patency, but still the jury is still out on how much of these endovascular AV fistulae can be all incorporated within our patient populations. But the fact of the matter is they do add to our armamentarium and give our patients additional choices. Next slide, please. But as I alluded to earlier about endovascular AV fistulae, is the need for innovating the process of care. How do we do cannulations in our dialysis units? How can we make sure that these processes of care, we've had a certain way of doing things, and you can go ahead, Jason. We have certain ways of doing things, and maybe it's time for us to look at them to challenge the status quo. So in this last part of my talk, I'm going to focus on the impact of cannulation related complications and see if we can change the status quo. Next slide, please. So when we think about needle infiltrations during cannulations, if it's a major infiltration, it does cause a lot of morbidity. It prolongs the catheter dependence for over 3 months. It leads to a mean of 2.4 additional interventions and fistula thrombosis in a quarter of the patients. And these effects are more pronounced in the first 6 months of a newly placed vascular access. Next slide, please. So what we did at Emory was we saw a huge amount of increase in infiltrations, and this was related with staff turnover. So when we look at objectively using ultrasound, whether we use it, you have the vein finders, people use it to guide difficult peripheral access. And of course, it's standard of care when we put in a dialysis catheter. So could we take the ultrasound that we use and train our frontline staff to use point of care ultrasound to guide hemodialysis access cannulations? Next slide. So our goal really was to empower our dialysis staff with the skills that they needed to use ultrasound. What we wanted to do 2 things. One, we wanted them to use it to guide their cannulation, but then we also wanted them to use it to assess their AV fistula for maturity. So to give you an idea of the scale of this project, We have 4 outpatient units at Emory Dialysis with around 750 patients. And the key barriers that we identified to ultrasound use was, one, we didn't have ultrasounds in all our units. And secondly, our staff were not trained. So we reviewed all the handheld devices in the market and picked the one that worked best for us and made sure that we had one in each unit. And then we also did a simulation workshop. Next slide, please. So our first simulation workshop, we've done a few since then, was a combination of didactic and hands-on components. In our first one, we had 18 participants who rotated through 5 stations. Next slide, please. So at the first station, we had a didactic lecture, just understanding the fundamentals of ultrasound, what is B mode, how the sound wave travels through the tissue and is reflected back towards the transducer, and how this velocity is converted into an anatomical depth. We also shared a color Doppler, how to look at the hue and figure out the direction of flow, emphasizing the mnemonic BART. Blue means it's flowing away from the probe, and red means it's flowing towards the probe. We did not do quantitative measurements. Next slide, please. At the second station, we got our staff familiar with the device. So how do you select the right preset, which is vascular access? How do you adjust the gain and the depth of the image? How do you freeze the image, take measurements, annotate, and then save and share these images? Next slide, please. On the third station, we taught them how to identify the vasculature, how to differentiate arteries from veins, keeping in mind that veins tend to be more compressible and arteries tend to be more pulsatile. They got to perform ultrasounds on each other and on simulation models. Next slide, please. And at the fourth station, they actually practiced cannulation simulation using these models. I've included a YouTube link here, which is where I learned how to make these models. Very straightforward with gelatin, Metamucil, and Penrose drains. And we taught them how to identify the needle, watch the tip, and then plan for visual maps or real-time guidance for cannulation. Next slide, please. So here you can see on the left-hand side, you've got a short axis with the needle. And on the right-hand side, you have a long axis where you can see the needle within the axis or the Penrose drain. Next slide, please. And on the fifth station, we discussed how they were going to assess an axis for maturity for cannulation. And we discussed the rule of sixes, which means that you should have a diameter that's at least 6 millimeters. It should be less than 6 millimeters from the surface of the skin, and there should be a 6 centimeter straight segment. There is another component of the rule of sixes, a blood flow of 600 mils per minute, but our device was not capable of flow measurements. We did emphasize that ultrasound is an adjunct. It's not a replacement for physical examination and clinical experience. And all of these need to be used together to assess axis maturity. Next slide, please. And then we did surveys both before and after the workshop. We asked them 4 questions. How confident are you with an ultrasound probe? Identifying an AV axis on ultrasound, assessing the maturity of an AV axis on ultrasound, and identifying a needle. And as you can see, before the workshop, they were not at all or somewhat confident, quite diffident. Most of them had never used an ultrasound before. This was our staff, our dialysis technicians and nurses. And as you can see, after the workshop, they felt increasingly confident. Next slide, please. And then it was time to put this in action. So we did a 6-month project looking at the effectiveness of ultrasounded guided cannulation on infiltration rates. We had a 6-month study period where we included all new AV fistula that were created and accessed during the study period, and all those who were accessed for the very first time during the study period, irrespective of when they were created. And we had our protocol that did physical examination and ultrasound assessments at regular intervals. The first 2 weeks post-op, 4 to 6 weeks post-op, where they were assessed for maturity, at the time of the first 1 needle cannulation and at the time of the first 2 needle cannulation. Next slide, please. And to minimize inter as well as intra-observer variability, we took depth and diameter measurements at pre-specified distances from the arterial anastomosis 2, 4, and 6 centimeters. Since then, we have amended our protocol to include a 4th assessment at the 8 centimeter mark as well. And we emphasized when they were using the ultrasound for them to aim for a circle at the middle of the screen so that there was minimal probe pressure and they were not compressing the AV fistula. Next slide, please. And then we used ultrasound to mark and cannulate all new AV fistula before their first 1 needle cannulation and their first 2 needle cannulation. We had weekly team meetings to discuss the progress and troubleshoot. Next slide, please. And so here are some pictures. On the left, you can see the arteriovenous fistula barely visible. On the right, you can see how we are doing a good physical examination, augmentation, and collapse. And then you can see the depth and the diameter measurements, the 3 lines, and then a visual map that was created, and then successful cannulation. Next slide, please. And we had 39 patients during the study period where we had the AV fistula that was both created and accessed, and 5 additional patients who were accessed for the very first time during the study period. So of these 44 patients, 2 died and 2 were transferred out before cannulation. That left us with 40 patients in the final analysis. 9 of these had primary failure. As I told you earlier, there's a very high risk of primary failure with surgically created arteriovenous fistulae, and our results were those that have been seen in other centers as well. 31 of these patients progressed in the study, and 29 of them were successfully cannulated. There was only 1 infiltration that was technically really a patient who had a femoral access, who moved 30 minutes into the treatment, dislodged the needle, and because we couldn't complete the dialysis treatment with needles and had to use her catheter, we included that as an infiltration, but technically it really wasn't a cannulation-related infiltration. Next slide, please. And what was even more impressive to us is not just the fact that we were able to use the ultrasound and really come down to minimal infiltrations, but that we were able to identify early those patients who had problems and were able to intervene and then successfully cannulating them, preventing further infiltrations. Next slide, please. But of course, we have limitations. That was a single-centered experience. I'm very happy to share that now many LDOs are looking at incorporating ultrasound into their practices. And the one thing that I do want to emphasize is that one workshop, it might provide exposure to ultrasound, it might give people hands-on practice, but it does not make a novice an expert. And it's critical for us to have regular practice and to evaluate even the best of your cannulators, evaluate their competencies periodically. Another limitation is time. Most of the culture in the dialysis unit right now is to keep people moving, get them on, get them off. And until you have a team approach, if the extra time that it takes for ultrasound to be incorporated into routine cannulation will not be successful. So the entire team has to buy into this process. Next slide, please. And we did find that after the workshop, if people didn't immediately pick up the ultrasound, they were a little intimidated. And because ultrasound is an added expense, we were putting the ultrasound under lock and key. And if people had to take 2 or 3 extra steps to get the ultrasound, they would not use it. And so to encourage that use, we did start keeping it in the center of the nurse's station and found that that really encouraged use. And it's one, see one, do one, teach one. So a lot of people have started using ultrasounds within our dialysis units. The one thing I would say is that real-time guidance requires either ambidexterity or a 2-person approach. So most of our cannulators preferred a visual map. We now have an update to the device where we can see in plane and out of plane at the same time. So we are now moving towards increasing our real-time guidance as well. Next slide, please. So to summarize the use of ultrasound, again, I can't emphasize enough that ultrasound is a complement. It's an adjunct to physical examination, not a replacement. But if you can add point-of-care ultrasound, it does provide a unique dimension to the management of hemodialysis vascular access. It's currently vastly underutilized, But with this new technology that's very easy to use and relatively inexpensive, we have shown that you can successfully teach it to frontline dialysis staff with even those who have had no prior exposure to ultrasound. Next slide, please. And so for dialysis vascular access, our goal really is to create a functional access that can be used repeatedly. We do have barriers that do not allow us to get the appropriate access for each patient, but these can be overcome with a multi-pronged, multidisciplinary approach, and access must be individualized for each patient. Every patient is unique, and we need to meet them where they are. We are their best advocates. Next slide, please. The ideal hemodialysis access does not exist yet, but there's a lot of innovation going on in this field. It truly is the dawn of a new era. And the goal really, we have to get to patient-centered approach, provide the right care for the right patient at the right time for the right reasons. Next slide, please. And so when we think about vascular access, it is our patient's lifeline, but it's also their most vulnerable part. It's their Achilles heel. And it's up to us to be able to move that pendulum towards moving it towards the best and the most optimal dialysis access. Next slide, please. And I'd like to end this by when I think about evolution in hemodialysis vascular access, I think of this quote from Vincent van Gogh: "As practice makes perfect, I cannot but make progress. Each drawing one makes, each study one paints is a step forward." So we are definitely moving forward towards the right direction, optimizing and individualizing dialysis access for each patient. And as the patient's advocates, that's our responsibility and our duty. Thank you so much for your time and attention, and happy to take any questions or any discussion afterwards.
Ben, really fantastic, Dr. Niyyar. I'm just going to turn it over to Dr. Ustaf. This really was insightful and informative with really cool devices too.
I know, I love those videos.
So Vandana, a couple of things. Actually, I just said the other day in the dialysis unit that access is the most difficult part of dialysis to a patient, because they were having issues, and I just said that. Did you train multiple technicians, or did you try and focus on a couple of people for new access? How are you all approaching that part?
So I have 2 vascular access coordinators, and we have a tiered approach. So we've got 2 people who are sort of like, we just transitioned to Epic, so the word super user is in my head. But we have these super users who are competent and confident and who actually know what they're doing. And the goal is really to have multiple people use it. So when I do my workshops, I've done 3 of them so far. It's around 15 to 20 people in each workshop. And then they practice in the unit. And so these access coordinators are going out, and each time they do an ultrasound, they do make sure that other people are using them and getting comfortable with them. I would say that we have perhaps in each unit 2 additional people as well who are comfortable with the ultrasound. They might not be experts yet.
Oh, got it. So you have the super user go first when they're getting ready to cannulate that fistula, and then afterwards, maybe more of the people in the unit who have been trained.
Right. First, always, like, one of my 2 access coordinators have to be there for the first cannulation as a 1 needle, and then the first cannulation as the 2 needles.
I'll ask another question. For your new Eclipse fistula, the one that you do endovascular, are the blood flows that you get with those fistula the same?
No.
Or what do you what kind of difference is there?
So you mean the blood flow on access measurement or the blood flow on the dialysis machine?
On the machine.
So on the machine, we are getting blood flows of 400, 350 to 400. They're not too low. And if we get less than that, because the problem is if it's less than that, they fail their KT over V.
Yeah.
And so you got to be able to keep the blood flow high. And so, yes, on the machine, so they are lower flows as far as access flow measurements, but on the machine, as long as it's, 350 to 400, we are good, and we don't have that problem. And if we do, we have to do interventions to make sure that the endovascular AV fistula matures.
Great. Dr. Krishnan actually has a question. One of our challenges is access peripheral vascular disease. Our population, good percent of whom are smokers. What were the outcome in smokers?
What was the outcome in smokers? Is it a question in the chat?
It is. I'm reading the chat.
Okay.
Mhm.
Okay. I don't think that they've actually done a specific sub-analysis on patients who were smokers, but I assume, again, not to have assumptions, but that's what we do in hypotheses. I think that you would see that patients who are smokers definitely have a higher incidence of peripheral vascular disease. And so, but I'm not aware that there has been a specific analysis looking at vein preservation in patients who are smokers and
Right.
CKD.
Well, certainly in the cardiology world, brachial artery, axillary artery, plenty of subclavian, plenty of atherosclerosis, and the radial artery seems to be relatively protected. And so as long as you're down in that area, it seems to should work pretty well. Another one from Dr. Emmons. Can you comment on the pace of development between artificial kidney and xenotransplantation, such as pigs, which will be dominant in 5 years?
So yes, I will say the artificial kidney, I think it was maybe 6 or 7 years ago when I started giving talks on, oh, this is coming. I'm so excited that the bioimplantable artificial kidney will be here, and it'll be able to, because the kidney has obviously the fluid part and then the electrolytes parts and the hormonal part. And the assumption was the wearable artificial kidney is currently in clinical trials. So people are actually wearing this belt that provides dialysis, but it's not very efficient. But, the pictures of the patients that we see in the clinical trials are people walking their dog while they're undergoing dialysis because they're wearing this belt, but it's not able to, the next step is that bioimplantable artificial kidney that he or she asked about. And that is, from what I understand, I actually talked to one of the investigators at UCSF who's creating that device, and they've run into trouble trying to be able to duplicate all the different parts because, of course, the kidney is, with all due respect to the heart, the most important organ in the body, and it's hard to duplicate that. So, but they are working on it, and now it's 4 different centers. I think Vanderbilt, UCSF are all working together to try and see if they can fine tune the bioimplantable artificial kidney. The xenotransplantation was very close to home for us. It was at UAB where they did that. And again, exciting. I just would wait to see how things are, because I was very optimistic when I saw the bioimplantable artificial kidney information coming out, but it's been 6 or 7 years. And I am still seeing that we haven't made as much progress, but I'm cautiously optimistic that we'll get there and it'll be faster.
Right. Well, so chuckling at which organ is more important. I'm actually the person who tried starting a cardiorenal clinic in a couple places. And so I'm really a big believer that they're equal, particularly with my focus on healthcare disparities and diet. That is, all the stuff that you've probably seen, that there is no end-stage renal disease if everyone stops eating red meat. That doesn't satisfy all the vegans, but the data is pretty strong. Because apparently there's this tight relationship between red meat consumption and dialysis. And obviously, in terms of health equity, our African-American population, 13% of the population and 35% of the dialysis patients. And what you're doing could really help with the burden that CMS has, over $90,000 a year for every dialysis patient because they qualify for Medicare no matter how old or young they are. So I really want to compliment everything that you're doing to make it better. And it wouldn't be great if we could eliminate this specialty completely. But I'm going on about society and medicine. I think Dr. Emmons has another question, which is all of your comments are all of your comments still the same for temporary emergent dialysis, as we often run into in cancer and transplant patients with infection, et cetera? I'm not sure if you can see the chat.
I can see the chat. I'm not sure, Dr. Robert, if you, Emmons, can you just, I'm not sure what the question is asking. Are all of your comments still the same?
We
Go
often
ahead.
have difficulties with patients who need temporary dialysis because of having sepsis or having a severe DIC episode or many other things that happen. Are all the comments about the placement of lines, the appropriateness of and the use of dialysis and the starting in the periphery, moving centrally, even given the difficulties with peripheral circulation that we often run into, and therefore may big difficulties in trying to get those veins accessed or arteries accessed. Where is the line different here in terms of the stable patient who comes for permanent dialysis versus the emergent person who needs temporary dialysis for some days or weeks?
Right. And I think that's a very good question. If you're talking about AKI versus patients who already have CKD, first of all, we don't know how many of those AKI patients are going to go to advance to chronic kidney disease or even worse, dialysis. I will say, just to give you a feedback on this, when we were trying to put together a venous access policy at Emory, for what it's worth, it took me 4 years to get through the multiple committees. And each time I would present and talk about where we should be starting and going from the dorsum. And I thought that people would think that it was too restrictive to try to have such a policy for patients with advanced CKD because we picked a GFR of 45. I was surprised when I got actually the reverse, where everybody said, why shouldn't we have this for all our patients? Because we don't know when we are going to become CKD or ESKD. And so going back to your question, it's like, you know, you don't know. Yes, ideally, you should try to follow this algorithm. I would say that I would avoid a subclavian access. Definitely. I know that our patients have lots of peripheral vascular disease, both peripheral venous as well as arterial. So it is hard sometimes to get something in the dorsum. And if you have to move up to the antecubital, but if you have a PIC, I would highly recommend using a tunneled IJ instead. That can, the risk of central stenosis with that is around 1 to 3%. And so, you know, you have to put everything in context. Yes, with an AKI, and then there's that whole discussion whether if this patient is in the ICU, whether you should be using a trialysis or you should have 2 separate lines. And I think both of those have their own pros and cons and well. But, you know, my default is, and unfortunately I have such a nephrocentric view, is that you never know when someone is going to become an AKI that may not recover and they might need dialysis in the future. So whatever we can do at our end is critical, and each little step counts.
Thank you for that. We often run into problems with PIC placement because the PIC team has a specific prohibition on placing PICs for certain levels of renal function. And we often have AML patients, for example, that require absolutely central access to get their chemotherapy. So we have to then default to a somewhat messier central line that can only be temporary, as opposed to a PIC line that can be, you know, a few weeks often in usage. So it makes it tricky when we have these arguments with them about these precise issues that have come from studies like yours. I certainly respect everything you said, but it just makes it challenging in these conditions in which we must have central access. We'd like it to be an intermediate duration, but we have to default to a temporary IJ, for example, that's put in by the ICU.
Oh no, how about a tunneled IJ? You can put in a small catheter, a tunneled IJ that works just the same. I can send Dr. Youssef the thing for the tunneled IJ. Is that not available?
No, well, it's the pace that's tricky because, again, we can get a PIC the same day. We can get a central IJ the same day. We have AML patients that need chemotherapy right away. Getting them down to IR or getting surgery involved will often delay things by days. And we don't have that time often. So we run into these discussions, therefore, because of the need for emergent access that must be central. And because the patient has AML and has a slightly high creatinine because of a high uric acid, which is going to change within 72 hours, we have to make decisions that aren't necessarily the best for the intermediate term.
I understand. I mean, I think it's all about, finding that balance and all of us getting together, like I said, multi-pronged, multidisciplinary approach, and whatever's best for the patient in that moment. I would say, yes, avoid it, but not in the long term. So
it sounds like one possibility for Dr. Emmons' group would be the development of a procedure service that's POCUS focused, as you've developed in your center. How easy is it to democratize? It was nice to see those steps of training, but how quickly do people who are experienced physicians or experienced, proceduralists, like, people who are certified in central lines, for example, do you think they could learn this quickly and be able to help Dr. Emmons' patients at point of care without having to go down to IR?
I think absolutely. I mean, there's a group that's actually doing tunnel dialysis catheters at the bedside in the ICU for that same reason. And when we talk about a tunnel IJ for peripheral access, that's a small French. We're not talking the big dialysis catheters. I think that should be relatively easy to enforce. It'll more be turf lines that will be the issue, where radiology may not give that up. But if, at our center, we just have a one click. So if you just try to put it in, and my assumption, or at least what I've seen, it happens the very same day. I've never seen it delayed to another day. But, I mean, I think every hospital, every center is different. And, but I do think that's something that could be done by the POCUS focus group as well. And, or by talking with IR and making sure that it happens like, within hours.
Okay. Dr. Youssef, anything else?
No, it was just a great talk, and you incorporate all the old, it's like very few people know the old history of dialysis. So it's nice that you were able to start there and show everybody where we're going and what we're doing now. And again, I love that this is patient-centric access. I think we're really moving forward. What will make the patient's lives better if they have to be on that.
Well, fantastic. And, the mark of a great grand rounds is that people start getting together and figuring out how to change the things that they're doing at our institution because of your grand round. So I really appreciate that. We really will get together and talk about having more of a POCUS focus because I think it can, based on what you're telling us, we can really have an adjunct to patient care that makes us better. So I really appreciate your time and expertise.
Well, thank you for having me.
And I know there, if just real quick, there was one more quick question that came in just at the end from Dr. Philip May. He's one of our community doctors. He attends very regularly. Wants to know, in addition to the right diet, is exercise good for dialysis patients?
Yes. So there's more and more data coming out that controlled exercise, monitored exercise. And so, well, exercise actually has been looked at two contexts, exercise as an overall well-being, and then exercise of the upper extremities to be able to increase the blood flow through the arms that allows us to get better accesses. And I will say that this has been a concern of mine. I don't want to take too long, but when I used to go to my children's swim meets, I would see these young children with really good, all I can see is veins. I'm very, very nephrocentric. So I would literally stop swimmers and ask them what exercise they were doing and take pictures of their arms because their cephalic veins were so well developed. And I'm still trying to figure out what would be the best exercise, but other people have been looking at exercise to try to enhance fistula maturation. But that's one of my pet future projects. I'm working on it.
Absolutely.
Jason, you're muted.
Yeah, I know it. So that's want to thank you, Dr. Niyyar, Dr. Youssef, for facilitating. This is another great talk, and we really appreciate it. And it's great to have one of our own come home, so to speak. And so I want to. We start tradition kind of started a few years ago, and it's for our. Although technically you're not a guest, but for our guest speakers, we have a little gift from the department, and it's something that's very synonymous with Louisville. So you will be getting your very own engraved Louisville Slugger bat.
Oh my gosh, thank you. I didn't know that.
Yeah.
Thank you.
You're welcome.
I will cherish that.
Yeah, so we will get the information, and we'll get that to you. So thank you again, and thank you everybody. And just a quick note, we'll be in person next week. So hybrid, we'll do our first hybrid session. Dr. Forrest Arnold from Infectious Diseases will be speaking about the triple-demic, and so we're looking forward to that. And we'll see folks online, but we'll see them in person too. So will be great. So so we appreciate everybody joining us, and we'll see.